Okay, we're talking about the functional divisions of the cerebellum. Vestibulocerebellum, associated with vestibular function and eye movement and coordination between those and your head and neck movement. Floccular nodular lobe is essentially what the vestibulocerebellum is. And also we told you it's also referred to as the archicerebellum, that older phylogenetically portion of the cerebellum. So the vestibular cerebellum, in order to elicit its influence, once it's matched up signals and said, hey, we need to make an adjustment to your head or your eyes to match up with what's going on, or neck and eyes, it does that by projecting from the cortex. Those Purkinje cells project to fastigial nuclei, those really center nuclei right deep in the center of the cerebellum, those most medial ones, right? And then also some of those goes directly to the vestibular nuclei. And so, the vestibular nuclei that are located in that pontomedullary region, they're almost considered as an additional deep cerebellar nucleus, because you do have some direct connections of Purkinje cells going to vestibular nuclei. Even though they aren't formally part of the cerebellum, they act like a deep cerebellar nucleus, okay, to help coordinate some of this stuff. In order to influence your trunk, neck, upper back, the vestibulocerebellum, those deep cerebellar, the fastigial nucleus and the vestibular nuclei use the vestibulospinal tracts, right? The vestibulospinal tracts, the motor tracts that go to your upper back and neck and facilitate posture and innervate those postural. That's how they exert their influence. Some of that also goes up the medial longitudinal fasciculus, okay? So some of that goes up the medial longitudinal fasciculus up to the eyes, which when you get to the vision and vestibular systems, they'll show that. Okay, so the vestibular nuclei have axons that project up what's called the MLF up towards your oculomotor muscles, okay, and those cranial nerve nuclei. Then we have the spinal cerebellum. So the spinal cerebellum is kind of in the middle of the cerebellum. It's that vermal and paravermal region, okay, so it doesn't match up with a lobe. It's that middle part of the cerebellum. When you're looking at the cerebellum, either from the front or the back, it's that middle region of the cerebellum, also known as the paleocerebellum. That middle region is called the paleocerebellum. So when you look at the spinal cerebellum and the spine, think spine, core, proximal, your spine and your body, spinal cerebellum. It influences coordination of trunk, but also spills a little bit into the limbs because it goes out into some of the girdle muscles of your limbs, okay? And also affects speech muscles, and helping coordinate your motor function of your tongue and mouth and face. The paravermal areas go out to that. This is where they extend out to that proximal limb musculature. So the vermis is really trunk and some limbs, but then paravermal regions are even farther down the limb into the proximal limb. And I don't know exactly where that ends, but not to the disc, not to your hands or not to your feet, but so it's a little bit of overlap here between the spinal cerebellum and the cerebral cerebellum. It's not like a straight cut. It's just a region that starts to transition from your more proximal areas to your more distal areas. So how does it influence how does it do its job? So once information is processed in the cortex, the Purkinje cells project to the fastigial nuclei, which so did the vestibulocerebellum, but also the interposed nuclei, globus and umbelliform nuclei. Then those fastigial and interposed nuclei, axons from there, project to the vestibulospinal, reticulospinal, rubrospinal, and medial lat. So basically everything. They project. That's where, because the spinal cerebellum and the vermis paravermal region there is, it's in that middle gray zone, and it does a little bit of everything. So if you have damage to your spinal cerebellum, you can see quite a few deficits. You just won't see that real distal ataxia. You can see truncal ataxia, speech problems, walking ataxia, proximal ataxia. So when you're testing distal, you'll still see a little bit that mild ataxia, that because you can't stabilize their proximal joints, but you won't see this kind of really, super ataxic distal stuff especially when they come into their nose. When cerebral cerebellar problems, as the closer you get to your target, the harder it is when you're trying to make really fine error corrections, and it just looks really bad the closer they get to the target. So they project to all those tracts to influence lots of different function. But again, more proximal, more speech, proximal muscles and trunk. Then the cerebellum, this is the cerebellar hemispheres, the very lateral parts, those pretty big lateral parts of the cerebellum. It's also referred to as the neocerebellum. This is for coordination of distal limb movements. Really important for the motor planning and programming, especially movement sequences, especially these fine fractionated complex motor sequences that distal limbs and distal parts of our muscles are more important for. The cerebrocerebellum, that part of the cerebellum, it projects to the dentate. Remember I drew that out yesterday and had it project to the dentate. And then that dentate projects up to the thalamus and then up to the motor cortex. And then it influences your distal limb function via, and I don't know why I don't have it on there, via the rubrospinal and cortical spinal tracts. Okay, so it's those lateral activating pathways, lateral cortical spinal and rubrospinal tracts, which that's how it exerts its influence. This is just a nice simple picture from your book showing color-coded. So here's your inner ear, which isn't located right there in the brain, but they're just showing it kind of there, how it's associated with that floccular nodular lobe, the same color there. So vestibular function, the inner ears, not, and it's the vestibular apparatus, not the cochlea. It doesn't have anything to do with hearing. It has to do with the semicircular canals, which sense angular movement of your head, rotation up and down, and angular movement. And it has the connections with that vestibulocerebellum or floccular nodular lobe. And then the spinocerebellum, which is that proximal muscle control, it has intimate connections with your spinal cord and via the vestibulo reticulolateral and rubrospinal tracts that all go down your spinal cord. Okay? And then your lateral hemispheres out here, the way they exert their influence is they send signals, back up to the cortex, and then the cortex, lateral cortical, and then even some rubrospinal tract influence to influence lateral distal control. This just shows you kind of the layout here. There is a somatotopic arrangement, and you can see where kind of the different regions of the body are located, with kind of speech right here in the center in the vermis, and the farther you get lateral, and they don't show these going real lateral, but you can see how the spine and the feet and hands and legs are kind of laid out on that. And they're showing this this is actually, they've taken this thing and basically pulled it out and stretched it out like this, because this part actually curves all the way under here and be way back under here. That's basically this guy being the other backside of this person underneath, kind of like tucked underneath there. So this is just showing this is the floccular nodular lobe that would be in here. And this is just showing the vestibulocerebellar output, how once you've processed information in the vestibular part or vestibulocerebellum in the cortex, the Purkinje cells project to the vestigial nucleus, but also directly to vestibular nuclei. So that's what this is showing. This would be like a Purkinje cell right in here in the vestibulocerebellar region. And it actually projects bilaterally, because a lot of our connections for postural muscles are somewhat bilateral in nature. And it projects to vestibular nuclei and exerts a lot of its influence through those vestibulospinal tracts. Okay. The thing they don't show here is it would also be projecting to the vestigial nucleus, that's most medial there. And then that vestigial nucleus would project to some of those vestibulospinal and reticulospinal tracts. Okay. This is showing you the spinocerebellar output, which is going both to, so the spinocerebellar is in the middle here. This gets really messy and murky here. The only thing you have to well, they're showing it here. This is showing like that would be kind of in that perivermal region. So this is a projection from a Purkinje cell to the vestigial nucleus. Then you see vestigial nucleus here will project to some of the vestibular nuclei, to some of the reticulospinal tracts. Some of this actually goes up to influence the lateral and rubrospinal tracts. So that spinocerebellum has connections and ability to influence lots of different motor pathways for coordination. And then this is what I drew out the other day on that little blank diagram, as far as here's the cerebrocerebellar output coming from the lateral cerebellar hemisphere, projecting to the dentate. The dentate projects up to both the red nucleus, but also to the thalamus, and then the thalamus projects up to the motor cortex to influence lateral cortical spinal tract coming down, and medial cortical spinal tract a little bit coming down from the cortex. But mainly lateral, because mainly distal. Okay. So key things here as far as lesions of the cerebellum. So if a person has a lesion in these select regions, you're going to at least see some of these symptoms. Okay. So if you see a lesion in the vestibulocerebellum, you'll see things like nystagmus. When nystagmus is this jumping of the eyes, when you ask the person to like track your finger, or if they do a quick head or eye movement, their eyes will often bounce or jump. That's like a ataxia of the eyes. Nystagmus is kind of like an ataxia of the eyes, where there's excessive bouncing or jumping of the eyes. They also have a sense of disequilibrium, like they feel like their head is swimming and they just can't quite figure out which way is up or down, potentially. This sense of disequilibrium. Not spinning. They don't feel like they're spinning. That's an inner ear problem. If you have one inner ear is out, it's kind of like a plane. You have two propellers that keep you going and keeps everything lined up. If one propeller goes out, you start spinning in circles. That's kind of like your inner ears. But if that's peripheral. That's a peripheral problem out in the inner ears, out here laterally. But if it's a processing thing, when it gets into your vestibulocerebellum, you just feel, ooh, I just don't feel like I'm very steady. I just don't feel like I can quite figure things out. I'm not spinning, but I'm feeling like disequilibrium. And then if they also have nystagmus when you test them, now you're thinking there's got to be some problem with connections between the vestibular cerebellum, the vestibular nuclei. There's got to be a lesion somewhere in that cerebellum and brainstem that's causing a problem with that sense of disequilibrium, causing this nystagmus. If it's a spinal cerebellum problem, if it's right in the vermis, they're going to have real bad truncal ataxia, if it's right down that center, plus they're going to have some dysarthria of speech. So they call it scanning speech is a term that's used for it, scanning. They're like kind of looking for the right pattern, and it's ataxic. It's hard to describe. There's videos, there's some good YouTube videos if you want to look at, a dysarthric speech secondary to a cerebellar problem. Okay, they'll have their cadence will go up and down, their volume will go up and down. They're just really having a hard time coordinating those muscles to keep that speech consistent. And it's like they're searching for that pattern, but they never quite get there. And they keep up and down with their inflection and their tone and their volume because they just can't quite get that. If it's more on the paravermis region, that's where you start to see more of the gait ataxia, because now these proximal muscles of the hip and shoulders and everything start to get involved, and you see a lot of gait ataxia. And then cerebrocerebellum, this is where you're going to really see the limb ataxia, especially the distal stuff, as they really try to come in, or they're doing the heel to shin, and you start seeing all kinds of crazy movements of the leg, and especially the foot, hand, and so forth. Other impairments, so this term ataxia, ataxia is kind of a catch-all term, and there's some other more specific terminology that fits under this whole category of ataxia, which just means lack of coordination. Things like dysmetria. Dysmetria is the inability to accurately move an intended distance. So when you're having the person do their test finger to nose, they'll do a couple things often. They'll go too far and they'll go past the nose and hit themselves in the face, or they'll stop short and then they'll go past. So this is dysmetria. It's the intended distance. Or if you have them trying to touch your finger out in space, they'll shoot past it or they'll stop before it. That's the dysmetric part of ataxia, is the inability to judge the distance. You can't sync it up, and that's because that's really important for your cerebellum to help sync the signal between the ones you're sending down, the information it's receiving from feedback from your muscle sensors to say that's the right distance or intended distance, stop by muscles from moving or make them move a little bit more to get there. So there's hyper dysmetria or hypodysmetria. Hyper is like somebody who really goes past the target a lot of times. Hypo would be somebody who's consistently short of the target. But a lot of patients have both. They go, sometimes they're short of the target, sometimes they go past the target. I love this next word, dysdiadochokinesia. So it's a fancy term for you can't do rapid alternating movements. And so they'll try to do them, and then they'll get out of sync, or they'll just be flopping, and then you're just trying to do their arms. Next thing you know, their elbows doing this, and they can't just do nice, clean, rapid alternating movements. Pendular movements, they just can't do nice, rapid pendular movements because remember, the cerebellum is really important for helping bolster the initial movement, but then shutting the movement down, and then so they're getting that quick transition from movement to non-movement is really important. So dysdiadochokinesia. An action tremor. Okay, so an action tremor is a shaking of the limb during voluntary movement. It's really not a true tremor. It's really a form of ataxia, but this is different than a resting tremor. So Parkinson's patients, basal ganglia problems have resting tremors like this. That's not ataxia, that's a resting tremor. And then when they move, it's smooth and it goes away. People with ataxia, when you just tell them to stay there and don't move, they're good. They look fine. As soon as they start moving, that's an action tremor. Okay, so that's an action tremor. And then often you'll have a slight amount of hypotonia with big cerebellar problems or lesions. There'll be a little bit lower tone, but it's not like flaccid. It's not even something, you have to know your stuff to lift their limbs up and feel their limbs and say, that feels a little lower tone than normal, and it takes practice and you may not even pick it up. So there's a little bit of potential hypertonia and maybe a slight amount of weakness. But it's not profound. It's not like hemiparesis, anything like that. And it's, again, all these symptoms are going to be on the same side as the lesion. If it's all right-sided symptoms, that lesion's on the right side of the cerebellum. Don't worry about this. This is just if you want to kind of have a big appreciation, though, I guess, for how the motor system works, this includes kind of everything. This includes the lateral corticospinal tracts over here, going directly down to the lower motor neurons. Shows you the rubrospinal tract and the red nucleus coming down. But then it shows you, this is the loop right here. This is the basal ganglia loop right here they're showing you. But then here's the cerebellum, and they're showing the role of the cerebellum in influencing all these different regions for coordination, and then how information gets into the cerebellum, these reciprocal connections. So it's just maybe, and then how it controls all these different movements down here. So it's kind of in one shot of a diagram of the relationship of the motor system, then its control circuits, the basal ganglia and the cerebellum, and how they all sort of communicate or relate to each other. So we're going to skip out of this for a second. We will do this one later. Any questions on the cerebellum? I tell you, I've got a little sheet that gives you what to focus on for that. Let's see, peripheral. So we're moving on real quick to peripheral nervous system disorders, or just the peripheral nervous system, which you guys learned in anatomy. You got all those spinal nerves and brachial plexus and lumbar plexus. You learned in anatomy. I'm not going to be, there's no diagrams of the brachial plexus or lumbar plexus coming up, so don't worry about that. The main thing I want you to understand about this is a couple simple things. All neural structures distal to the spinal nerves. So once the spinal nerves kind of come together from those dorsal roots and form that spinal nerve, that's what we're considering peripheral nervous system. Although the spinal nerve roots and rootslets are still kind of peripheral nervous system. It's just that, you have those anterior horn cells. You have a cell body lying within the central nervous system, and then the axons projecting out into that nerve roots and nerves. But once you get into the spinal nerves, you can definitely know you're in the peripheral nervous system. So any damage from the nerve out will cause peripheral nervous system disorder or problems. You get bundle of parallel axons, okay? And remember, these are mixed nerves. These have, once you get into the spinal nerve, once those two roots have come together, now you have everything. You've got motor, sensory, and autonomic if it's in that T1 to L2 region, okay? So T1 to L2 is going to have some autonomic. The ones above and below, now the sacral is going to have some autonomic as well, parasympathetic sacral fibers in S2 to S4. Cervical is not going to have any, the cervical spine doesn't have any sympathetic or parasympathetic information coming out of it, okay? But we do have the cranial nerves, which we're not talking about, which are peripheral nerves. Cranial nerves are peripheral nerves, but the cranial nerves are also mostly mixed nerves, but they're not all cranial nerves have sensory, motor, and autonomic. Some are just autonomic, some are just motor, some are a mix, so it gets a little more dicey. But if we're in the T1 to L2 region, which is a big part of we're going to have some type of, sympathetic, autonomic function. We're going to have some type of motor, some type of sensory coming out of it, okay? So for the most part, your peripheral nerves are mixed nerves. They are in these parallel bundles, okay, and they're in 3 connective tissue sheaths. So you have an endoneurium, which actually wraps around individual axons and myelin, okay? A perineurium, which then groups a bundle of axons. And then you have an epineurium, which goes around the entire nerve trunk, okay? So you have 3 different connective tissue layers or sheaths. So this shows you that picture here. So starting with the endoneurium, which is this stuff right here around the individual axons and the myelin. This substance in here is all endoneurium. Then you have perineurium. So perineurium is this very outer that bundles a group of axons together, okay? And then you have the I forgot to do the whole, but we'll only have a couple slides. So this is the epineurium out here. All this stuff out here around those bundles of perineurium and fascicles of axons are the epineurium. And then you'll see this, so this is a nerve. This would be just a peripheral nerve. Could be a spinal nerve, could be out to like the median nerve, ulnar nerve. It's just a nerve that has all those in it. And then you'll see blood vessels in there too. You got to get blood supply to those nerves as well. So you got blood supply running within those nerves. So each of these layers provides some protection. And so when we talk about damage to the peripheral nerve, it's which part of that protective layer do you damage that becomes important for repair, recovery, and those kind of things. This is review here, but this is just showing you, when we talk about peripheral axons, we've talked about how you classify them and name them. And so generally, so we have efferent axons. Those are our motor axons or our autonomic motor, our visceral motor axons, so things that go away from our central nervous system. So to go to skeletal muscles, to go to organs, whatever, that take signals out, those are efferent axons. And then we have afferent axons. If they're large and myelinated, if it's a large and myelinated and it's an efferent axon, it's likely going to be an A alpha, okay? It's an alpha motor neuron, right? And that's A alpha is the type of axon that's coming out from like an alpha motor neuron. Now we have the alphas and the gammas, okay? And if it's an afferent axon, a sensory axon coming in, and it's a large myelinated type of fiber, it's going to probably fall under a 1A, 1B, or 2 classification. That's coming from muscle spindles, Golgi tendon organs, some of our specialized touch and Pacinian corpuscles and Merkel's discs and those kind of things. Those tend to be some of those 1A and 1Bs and 2s. If it's more of a medium myelinated fiber, it's going to be an A gamma if it's an efferent axon. Remember, they're a little slower, but remember we said those fire, sometimes they're a little smaller cell bodies, so they still fire and get the signal to the area in a decent amount of time. So this is going to the muscle spindles, interfusal muscle fibers, the muscle spindles, A gammas. You really don't have an equivalent medium myelinated for an efferent axon. You jump right here to more what we call small myelinated. So these are smaller axons, but they are myelinated. We do have some, haven't talked about this before, an efferent axon. So the preganglionic, presynaptic, preganglionic axons that are coming out for like your sympathetic nervous system and some of your sympathetic and parasympathetic nervous systems coming from those S2 to S4 or T1 to L2 segments, those are medium myelinated axons called B fibers. Okay, B fibers. And then from an afferent standpoint, or pain and temperature, the A delta fibers. They're on small but myelinated. They're still called fast pain fibers, okay? But those are the A deltas. And then unmyelinated, the postsynaptic autonomic fibers, so after the postganglionic fibers for your sympathetic and parasympathetic nervous system, are still kind of slow, but they're carried on C fibers, just like the afferent axons. For pain and temperature, the slow pain and temperature pathways are carried on C fiber axons. So this is the only place where you have C fibers, both for efferent and afferent, where you have that same nomenclature terminology used to describe the type of axon. So don't let that confuse you. And your exam, though, is just over the motor fibers, so you need to focus on those guys, the efferent axons, for this coming exam. Peripheral nerve disorders. We have a variety of peripheral nerve disorders that can affect us. Mononeuropathies. If you have a lesion that affects a single peripheral nerve, like a radial nerve, like an ulnar nerve, like a femoral nerve, that's considered a mononeuropathy. And it's only affecting a single final peripheral nerve distribution. Okay, so that final peripheral nerve distribution is a mononeuropathy. Those aren't that, they happen. Carpal tunnel is probably the most common mononeuropathy. You can have carpal tunnel in both hands. It's still considered a mononeuropathy. It's just one nerve in both hands. It's still a mononeuropathy, even though it's in both hands. And most people have it just more in one hand versus another, but if you got somebody doing assembly line work and so forth, they could have it in both hands. It's common during pregnancy as well to have it in both hands because of swelling. So, your question, Amir?
Like sciatica, because sciatic nerve contains two nerves, is it still considered?
Yeah, it would still probably fall into that classification. That's a good question, but it'd be considered probably a mononeuropathy still once you get out past the nerve root and you're out more distal. A sciatic nerve would be probably classified. That's a good point. Multiple mononeuropathy. Now, some people will say I have sciatica, but it may be coming from a spinal nerve root problem. If the pressures at the piriformis or something down out here versus up in the spinal region, you can have, so that gets a little murky. With some people say, oh, I've got sciatica, which could be caused by a spinal nerve root that contributes a lot to the sciatic nerve and goes down the sciatic nerve. That would still be a radiculopathy. But if you actually had pressure like from a piriformis syndrome or something out there past where the spinal nerve root is, that would be more like a mononeuropathy classification. So there's things called multiple mononeuropathies, which are fairly rare. Diabetes can cause this, but it's not. Diabetes is typically considered a polyneuropathy. Most commonly with multiple mononeuropathies, I guess you could say if somebody had bilateral carpal tunnel syndrome, it might fall under this multiple mononeuropathies classification. There is a unique inflammatory blood disorder or blood vessel disorder where you get this inflammation of blood vessels that are specifically in nerves. and can lead to these multiple motoneuropathies where they get this autoimmune inflammatory response within their blood vessels that are inside their peripheral nerves, and it looks like these multiple motoneuropathies. It can be kind of unique how it presents itself. I forget the exact name of that disease or disorder. Then we have radiculopathy. So radiculopathy is when you're primarily affecting the spinal nerve as it just after those roots come together, okay, right around as it exits the spinal column. So usually a disc herniation or something like that's going to cause that, or foraminal stenosis where it's coming out of the foramina and you've got stenosis or narrowing, a little osteophyte or a little arthritis around that that pushes on that spinal nerve before it starts branching into its peripheral nerves. That's a radiculopathy. Then our polyneuropathy, diabetes is considered a polyneuropathy because it affects lots of nerves. And polyneuropathies tend to affect it somewhat symmetrical. Both arms, both legs, the whole body are symmetrically affected, and it's lots of nerves. And Guillain-Barré would be a polyneuropathy. Polyperipheral neuropathy, because you're affecting the motor part of it primarily. You're affecting those anterior roots, but lots of nerves, so it's a polyneuropathy. When we talk about peripheral nerve injury, now damage to the peripheral nerves and how that occurs, this is the little chart you want to know. So this is the one you want to review. There are two different classifications. There's a Sunderland classification, which is a Roman numeral classification, and there's a Seddon classification, which is just a descriptive term. And you'll see in the Seddon classification, there's only three kind of categories of terminology they use to describe these injuries, but you can get a little more fine-tuned with the Sunderland classification within those categories, okay? So let's start with number one, Sunderland classification 1, which can refer to as a neuropraxia. So if you hear the term neuropraxia, patient has a neuropraxia, that's the lowest level of impairment of a peripheral nerve. This is just disruption of the axonal myelin. So just the myelin gets a little disrupted. You push on it, you smash the nerve or lack of blood supply, and the myelin just starts to degrade and degenerate. There's no damage to the axon itself. It's just the myelin around the axon. You get complete recovery. It can occur over a period of days to months, depending on how severely you damage that myelin and how big a section of nerve that myelin is affected in, okay? You're not having to grow anything back. I mean, you're not having to grow the nerve, you're just having to grow the myelin back, replace the myelin cells, the Schwann cells. And in the periphery, you have nice nerve growth factors that allow that to occur. In your central nervous system, if it's an oligodendrocyte and you have MS, you don't get that kind of repair. In the peripheral nervous system, you get great repair. And that's why the problem with MS is that it happens in the central nervous system, and those oligodendrocyte cells, those myelin cells, and they don't repair or replace themselves as well. And some of the research on MS is looking at how do you trick the nervous system to repair oligodendrocytes. So it just happens naturally in the peripheral nervous system. A Sunderland classification 2, which now we're into what's called an axonotmesis. Okay, an axonotmesis is some damage to the axon. Okay, so now we get disruption of the myelin and axon, but if it's a class 2, the endoneurium is still intact. So now you're damaging the myelin and the axon inside, but that endoneurium around that axon and myelin is still intact. You haven't disrupted that endoneurium. You've just messed up the axon and the myelin inside that endoneurium. Okay, that most intervasicle, that little vasicle, that little layer of wrapping around the nerves. You get typically complete recovery here in anatomic order. And time to recover is a function of the rate of axonal regeneration. So because you haven't disrupted the little tube that all this stuff's contained in, it has a nice, it's all contained in there, and it starts to grow back or repair itself and goes to the right area of the body, you know, the skin or the muscles, because it's staying within its endoneurium, okay? and it recovers in the order that you lose it. So like if you damage a nerve, typically you're going to have some distal loss of either sensation, motor, autonomic, and then as it gets better, it gets better from proximal to distal. So you have loss of distal to proximal. The farther it is away, the harder it gives the signal there, but then you recover proximal to distal. That's what we mean by anatomical order. You recover proximal to distal. So your Guillain-Barré patient will first of all start to notice that they're having trouble with, like, my toes, I can't lift my feet up. Now all of a sudden my knees feel weak. Now all of a sudden I can't breathe. You're having problems from distal to proximal because as the nerve degenerates, it's harder to, initially you pick it up distally because it's harder to get those signals to those farther away places. But then as they get better, they notice that, hey, my trunk muscles are getting stronger, my hips are getting stronger, but my feet aren't doing anything yet. And you have to wait for recovery, for that. But you can start working on strengthening their hips, and you're giving them maybe some braces to keep their toes up until the nerve regenerates and the myelin regenerates so they can send signals all the way down to their feet. Okay? Now we're still under this classification of axon-otmesis. Now we're in Sunderland classification 3. This is you get disruption of the myelin, axon, and endoneurium. So now you start to mess with the endoneurium around each individual axon and myelin. But the perineurium is still intact. This you may get incomplete recovery now instead of complete recovery because disruption of the endoneurium allows some regenerating axons to become misrouted. They might go to the wrong muscle, the wrong area of skin, and so forth. However, typically with that, your brain figures it out. And then it's not a problem. Once it integrates and says, oh, now this nerve is going here instead of where it used to be, and you can reintegrate that. So you get mostly good recovery with that, with the Sunderland classification 3. And then number 4, classification still axon-otmesis, disruption of myelin, axon, endoneurium, and perineurium. So now you've got endoneurium and perineurium, but the nerve itself, the nerve trunk, that epineurium is still intact. This is where you got a problem. This is now, once you disrupt that perineurium, now there's a pretty good chance you're not going to get recovery unless surgical repair is undertaken. When we talk about surgical repair, what they basically have to do is they take the nerve, and usually the nerve has been crushed or just disrupted in some way or damaged. They have to cut it out, the bad section, and sew with microsuturing under microscopic, and they sew the nerve together so you get clean ends for the recovery. And it can repair, but it's typically not perfect still. I mean, you can get nerve recovery with that, but it's still typically not perfect. You still maybe have some weakness, some sensory loss, but you can get some recovery with that. And they're getting better all the time with doing those nerve actual transplants and nerve, where you cut it out and resew it together. Sunderland classification 5, this is where we have neurotmesis. Neurotmesis is complete nerve transection. Nerve is totally disrupted and the ends are apart from each other, okay? And you have to cut the bad end, they have to cut the rag ends off and sew them back together or else nothing's happening. You're not going to get in a repair with that, okay? A 6 is not really worse, even though you say it's a 6, it should be worse. That's just a mixed nerve lesion. So you have some nerves near each other. Some may have been pulled apart. Some may have been crushed. So actually it's pretty common to have a mixed nerve lesion if you have a big injury that involves a couple nerves or big nerves and get some mix of injury there. And so the recovery depends on with the amount of damage to either the perineurium, epineurium, Schwann cells, or if you've got a true axonot or neurotmesis. If you have an axonotmesis, they talk about recovery rate of like 1 millimeter per day. So these classifications typically more down this 3 and 4 region, and sometimes 2. But once you get to axonotmesis, is where you can get this recovery rate of like if the person has, so you can almost like measure, like if the person damaged, their common peroneal nerve and they have foot drop, and the distance from the common peroneal nerve where they damaged it here down to the motor point where it goes into the anterior tib, you can measure that and you can estimate out a millimeter a day kind of thing. So, and I think that that gets close to equivalent of like an inch a month or something like that. So, you can look how many inches and how many months. But I never try to tell my patients that plan on that. I just say, I give them very wide, big ranges. Like this could take anywhere from 3 to 18 months. Because it can. We just don't know exactly what's going on with that injury and how bad it was. So the chances if somebody if it's not completely transected, actually one of my friends from PT school, he was skiing and his ski popped off, freak injury. The ski popped off and just cut and transected his common peroneal nerve. And by the time they got to him and all that, they really couldn't repair it very well. And this is before they were doing good nerve repair. Now maybe they've been able to go back in. I haven't talked to him in years. But he's not going to get any recovery. He's not going to get recovery each a month or that kind of thing if you've got a complete transection of that nerve. So he was wearing a carbon fiber AFO and all that stuff. But any questions on peripheral nervous system stuff? Pretty simple. That's the stuff you got to focus in right there, those slides and those tables.